A patient presents in the clinic with extreme fatigue and massive systemic fluid backup. Yet an echocardiogram shows that their ejection fraction, the percentage of blood leaving the heart each time it contracts, is completely normal. The heart is squeezing with plenty of force. The central motor is fully functional, but the patient's cardiovascular system is still collapsing. This diagram shows why. Watch the ventricle's cross-section complete a contraction. Reaching the filling phase, it fails to expand. This is restrictive cardiomyopathy, or RCM. The pathology occurs strictly during diastole, a mechanical inability to accept incoming blood. It's a can't-fill problem. This ventricular rigidity is driven by two mechanisms: physical scar tissue locking the walls in place, and a microscopic biochemical failure preventing the muscle fibers from relaxing. We will trace this disease chronologically, from the initial cellular insult through the hemodynamic consequences, all the way to systemic biventricular organ failure. To understand RCM, you must look past the heart's ability to pump. The entire pathology stems from its inability to yield to preload. Preload is the initial stretching of the cardiac myocytes prior to contraction, driven by venous return. This diagram illustrates step 1. The cycle begins with abnormal substances infiltrating myocardial tissue, causing injury. The first pathway is amyloidosis. Misfolded proteins aggregate into amyloid fibrils, depositing between cardiac myocytes in the interstitial space, physically crowding the cells. In hemochromatosis, excess iron is absorbed and enters the myocytes directly. This triggers the release of reactive oxygen species, or ROS. ROS are highly reactive molecules, causing severe oxidative damage and cellular injury. Sarcoidosis introduces chronic inflammation. It forms granulomas, clumps of immune cells, that sit directly inside the myocardium. The final common pathway is radiation or general fibrosis, causing direct injury to the cardiac muscle. Whether the infiltration originates from misfolded proteins, iron overload, immune cell clumps, or radiation, the immediate result is severe cellular stress. The uniform, highly elastic structure of a healthy heart muscle is replaced by a damaged, crowded environment. This structural disruption triggers an aggressive healing response. The myocardial tissue attempts to repair these infiltration injuries. This animation shows the cellular response. The initial injury activates fibroblasts within the heart muscle, which migrate to the site of the damage. These fibroblasts aggressively lay down a scaffold of type 1 collagen, replacing the functional, elastic myocardium. Healthy myocardium is stretchable, but type 1 collagen is a dense, rigid structural protein that is entirely non-elastic. As collagen replaces muscle, the macroscopic consequence is a severe drop in ventricular compliance. Compliance is the physical ability of a hollow organ to distend and increase volume under pressure. The loss of compliance directly limits diastole. The ventricle now physically resists stretching during the filling phase, creating a rigid barrier. The heart is mechanically imprisoned by its own scar tissue, unable to expand to accept a normal volume of incoming blood. Structural scarring is only half the problem. The ventricle is also experiencing an active biochemical failure that prevents cellular relaxation. This inset diagram shows normal diastolic physiology. It requires active energy to remove calcium from the cytoplasm so the muscle can relax. This removal is handled by the Circa pump, which actively transfers calcium ions back into the sarcoplasmic reticulum. In restrictive cardiomyopathy, this Circa pump becomes dysfunctional and fails to clear the calcium efficiently. As a result, calcium levels remain elevated in the cytosol for prolonged periods. Because calcium triggers contraction, this residual calcium forces the myocardial muscle fibers to stay in a state of partial contraction, even when they should be resting. The ventricular wall is encased in a rigid collagen scaffold and biochemically locked in a contracted state. This combined impairment creates massive diastolic failure. This fluid dynamics animation tracks what happens when normal blood volume encounters this non-compliant ventricle. The incoming blood is physically rejected by the stiff walls. Because the volume has nowhere to go, filling pressures inside the heart spike exponentially. This pressure has to vent backwards. On the left side, elevated pressure travels from the left atrium directly retrograde into the pulmonary veins. This pulmonary congestion causes clear clinical signs: shortness of breath, orthopnea, crackles in the lungs, and eventually pulmonary edema. Orthopnea is shortness of breath that occurs when lying flat. On the right side of the heart, the elevated pressure travels from the right atrium retrogradely into the systemic venous circuit. This systemic backup forces fluid into the tissues. Patients develop jugular venous distension, hepatomegaly, an enlarged liver, peripheral edema in the legs, and abdominal ascites. Restrictive cardiomyopathy is distinctively a biventricular disease. Because both ventricles are typically infiltrated, patients frequently present with right and left heart failure simultaneously. While fluid backs up behind the heart, forward flow collapses. Because ventricular filling is drastically reduced, the stroke volume plummets. Stroke volume is the volume of blood pumped out during each contraction. This crashed stroke volume drops the overall cardiac output. The patient experiences severe, debilitating fatigue, even though their systolic squeeze remains perfectly preserved. This flow chart details the linear cascade of restrictive cardiomyopathy from cellular origin to clinical presentation. Infiltration causes tissue injury. That injury activates fibroblasts to deposit rigid collagen, creating a mechanically stiff ventricle. Circupump dysfunction compounds the problem, causing impaired cellular relaxation. The ventricle's inability to fill drops preload and forces pressure exponentially backward into the atria and venous systems. These high retrograde pressures create severe pulmonary and systemic congestion, while the lack of forward flow drops cardiac output. By understanding this strict, mathematically driven cycle of pathophysiology, you can derive the complex clinical symptoms on the fly without relying on rote memorization. Restrictive cardiomyopathy proves a heart doesn't need to lose its contractile strength to fail completely. It only needs to lose its structural ability to yield.